Very warm welcome to the second exercise in biomedical microsystems. Today, I'd like to introduce you to knee joint prosthesis, and the question will be, what kind of microsystems can I use to improve the performance of knee joint prosthesis? So I learned from the first recording, and therefore I'm supposed to make a break between each and every slide, that you are able to follow the slides much better and don't have blankouts or whatever losses of my explanation. Joint prosthesis. So we are talking mainly about artificial hips, wrist prosthesis, and knee prosthesis, where the majority goes on hip and knee prosthesis, where we have about 3/4 at least of a million in hip and knee prosthesis per year. So that comes from an aging society on one hand. People are more active, people get older, and people have an increased weight. And this all contributes to the fact that the hip prosthesis and the hip joints and the knee joints fail, and we have technical replacements to maintain mobility of the respective joint. So, what do we have to know with respect to anatomy and physiology? First of all, the motivation. To be able to develop and to manufacture good prosthesis, we have to understand the challenges in restoring the lost functions. So, let's look into the anatomy of the knee joint first. You have to learn the names of the bones. For example, that's the first one. So we have the thigh, that's called the femur, and we have the shank consisting out of the fibula and the tibia. We have the meniscus, we have several of them, and in Latin that's called the menisci. They're there to allow sliding of the joints and also to provide a little bit of damping under mechanical load. And we have the ligaments that are kind of straps that maintain the position of the joints and stabilize them. And for actuation, we have muscles that actuate actively the movement over the joints and help to stabilize the joints. So the bones. First, as already said, the femur or the thigh bone is the upper one above the knee, and the tibia, the shin bone, is below the knee. The fibula is the calf bone, and the patella is the kneecap here in front of that. To understand the actuation of the knee and to understand the design of knee prosthesis, we have to look on the knee from different directions. If we look from the side, this is called lateral view. If we look from the back side, that's called the dorsal view. And if we look from the front side, that is called the ventral view. The knee joint in Latin, it's called articulatio genus. So here you see the kneecap, the patella, and we see that we have some surfaces here that slide onto each other, so we can bend the knee. And as you know from yourself, we also have a kind of rotational freedom there. When those two surfaces slide on those two surfaces, we can rotate a little bit here the lower part of the knee versus the upper part of the knee. If we look inside the knee joint, what do we find? We look on the menisci here that form kind of socket for the joint, that the joint stays in place, and they're made out of fibers and cartilage here, and they work as shock absorbers, and that means they have a multi-layer graduate Young's modulus there that allows shock absorption and keeps everything in place. And we have here those ligaments that help to keep things together. Knee joints have the highest cartilage thickness between 2 and 7 millimeters, and as you can see here, the bony structure really helps to take the load and guides the load to the bones. If you grow older, it could happen that your thickness here of the ligaments, not the ligaments here, of the meniscus is reduced, and this causes pain if the bones slide on each other. If we have now a closer look on the ligaments, we observe that they connect one bone with the other bone and keep the bones in place while leaving enough freedom for movement. And that is the important part, and you might have heard from accidents where your ligaments are destroyed, then the stability of the bone is no longer there. So here the cruciate ligaments, they avoid displacement of tibia and femur, and then we have the others here, the transverse, the patella, the medial and the lateral one, who further stabilize the whole knee. At the outermost layer, we have the muscles for actuation and stabilization. And if you imagine that you would have a joint with a bone above the joint and a bone below the joint, you would need muscles passing that joint for movement. So looking here on the biceps femoris, this muscle is anchored close to the hip, and the other end is on the fibula. So if the muscle shortens by contraction, you get a movement. And since he has two heads, one on the dorsal side and one on the medial side, one on the lateral side and one on the medial side, and we look from the back, from dorsal, and those two muscles shorten here, the knee is bent. If we look from the ventral side, so the front side, having the rectus femoris and the vastus lateralis and vastus medialis, M stands for muscle here, and those two or three, they contract, then we have a knee extension. That means the bent knee gets straight again. Here the extensors, so stretching the knee, and the flexors, bending the knee. Semitendinosus and semimembranosus are summarized in English language and are called the hamstrings. And as you can imagine, having strong muscles, you can counterbalance flexing and extensing of the leg, which is extremely important when walking down a ramp, when walking downstairs, really to take the load from the knee. And if you go downstairs, the sevenfold of your body weight is imposed on the knee joint. That means it's easy if you have enough weight to have more than a ton on a single step on your knee joint. So, as said, this is for active protection and strengthening of the knee joint. That means muscle training really helps also to keep your joints healthy and stable. A little thing that we all have is the patella. So the cap, it slides as the knee moves and reduces friction between the filaments and the bones, shown on the right hand side. You have here the patella, and the ligament goes on top. If you take one of your hands and place it on your knee, and you relax the muscles, then you can actively move your patella a little bit, showing that it's really there and that's movable and that it's not fixed to the bone. So force transmission goes from the femur to the tibia here, and we protect and stabilize the knee joint. What problems can arise in diseases? So we have chronic degenerative diseases. That comes just behind lower back pain. And what we see here is that we can have destroyed cartilage. And there are many, many reasons for that. So the reasons for knee injuries is that we have high loads in everyday life, and in combination with variations from human to human, so non-optimal fit of the joints due to personal development after birth, little coverage with soft parts, or the combination that we really have large bones, long length, gives a lot of torque on that. And then degenerative diseases like osteoarthritis, that causes here the degeneration of the bone and the cartilage and leads to non-proper fitting in the knee joint. So one option, and this is really the last resort option before trying out other things, is to surgically replace parts of the knee joint or the whole knee joint. And this is where medical engineering comes into the game. X-ray figures how it might look like. What do we have? So we have here either a unicompartmental replacement, that means only one part of the knee joint is replaced on the femur and the tibia. So we have the sliding part on the upper half, and we have kind of the bearing, so the part which is the socket on the lower part. We can have a bicompartmental prosthesis. That means we have complete replacement of the upper part and the lower part. And you see the challenge that the surgical intervention has to cut off just the right amount of bone and to fix the prosthesis into the remaining bone in a way that the length of the leg is maintained, that you have a little place in between two parts for movement, but not too much that the whole knee joint is still stable. In the most severe part, you have a 3-compartmental prosthesis. That means here now, from a lateral view, you see the upper part with a bolt in here to keep the whole thing in place. You have a replacement of the patella, and you have a replacement down here where some screws are shining through that show the fixation inside the bone. So what requirements do we have? On the right-hand side, some designs, some figures of approved knee joint prostheses that are used in clinical practice. The requirements are that the whole stuff is biocompatible. That means it should not cause any harm to the body, neither by the material itself, nor by residues, nor by wear. That means small particles when the knee joint is moving. We have here the tibial plate with the stem. We have that's made out of metal here in this case. We have the upper part made out of metal, the sliding part for the femur. And we have here the sliding, kind of the bearing here, made out of polyethylene. Has to be a very special, very hard polyethylene that it can provide sliding, but does not get deformed with a high amount of load. That's here the articulating surface. Now on a lateral view, the patella, femur, and the tibia. So must be fatigue resistant. That means it should work for years. And this is a huge thing now, that those knee joint prostheses should last for 15 to 25 years. That means having an average life expectancy of 80 years. That means minus 20, 25, 60, 55 years would be an early age to get one. If you are a sports person, probably you need it earlier. So in early days, the life expectancy of such an implant was less than 10 years. So a lot of progress has been made with respect to materials development. It should be ductile. That means it should ductile enough that you have no breakage when experience load. In the best case, you have an osseointegration. That means the bone here around the implant grows tightly inside the technical material and fixates the material in place. So no corrosion at all. Don't want to lose your implant by corrosion. Little abrasion. That means no little particles or only few little particles while moving one part on the other. It should be kind of lubricating effect like in a bearing, but you cannot put oil or something like this into a knee joint on a daily basis, so there must be some outer lubricating surfaces or surfaces that allow body fluid to come in. Fixation must be stable, that you have a stable walk and stable stance. And as said, should overtake a ton or 1.5 tons or something like this. So you really need high mechanical load capacity. What does that mean? That means we have to select materials that are adequate for joint prosthesis. So in the early days, people tried out a lot of things, and it came down to cobalt chromium alloys, most widely used together with titanium. We have here titanium and titanium alloys with a little bit of aluminum and vanadium here to make it more ductile and more stable. We have oxidized zirconium with 2.5% niobium, and the trademark from Smith & Nephew is oxinium for that. Or we have zirconium alloys combined with all plastic tibial components. This zirconium could be also zirconia. That means we might have ceramic materials in prosthesis. The sliding parts that come on top are made out of polyethylene, and this polyethylene PE has a lot of letters in front of that. So the first one here is ultra high molecular weight polyethylene, or ultra high cross-linked polyethylene to have a high stability. We have implants that need no cement. Cement is used as a kind of glue, but we might have uncemented implants, either made out of tantalum with a trabecular mesh in the metal and pores that the bone cells can grow into that and fixate the whole implant. Second option is a coating made out of hydroxyapatite. Hydroxyapatite is a very complex crystal where phosphorus, oxygen, and calcium are incorporated, and this is the material where the bone is made of. And if we have hydroxyapatite there as coating, the body attacks on one hand the hydroxyapatite and resolves it in 3-calcium phosphide, and this is a reversible reaction depending on the pH value of the surface and the composition of hydroxyapatite and tricalcium phosphate. And by that we get the dissolution and deposition where bone cells grow into the hydroxyapatite surface and build an anchoring structure with the stem of the implant. That means you have to remember we have cemented knee joint prosthesis or cement-less knee joint prosthesis. Cement means here really, as you know it from construction sites, this is really cemented, so glued, fixated with a third component, the cement. That's a modified PMMA, polymetal, so plexiglass, polymetal metaculate, and this is filled in between the space between the prosthesis and the skeleton. So the good thing with that is you have immediately a fixation. As soon as it's hardened, it's fixed. Downside is if you have a kind of glue, there might be an adhesion failure between the glue and the bone, or the glue and the implant, or a cohesion failure inside the glue. So therefore, cementless implants have been developed. You have a fixation through a press fit, so you really have to hammer it into the bone, and you have a rough surface, and with that you enhance the friction and you enable intergrowth here of the cells, and then the cells really fix it. And if there will be a failure, it's really a failure between the bones and the implant structure, and no failure via a third material in between. You can imagine there are many different ways to do that, and there are hybrid approaches where the femur is cementless while the tibia part is cemented. How to choose now the material for such a prosthesis? Well, it's mainly done by the doctor or the surgeon, well, together with the patient, based on previous success, not of the patient, but of the doctor. And cost comes into the game depending on your health insurance or age. So, how old are you? Are you already 75? Then you probably do not need a prosthesis of the same materials that a 40-year-old might need. And also allergies come in. So if you're allergic against nickel, you should not take a prosthesis material that contains nickel, for example. So here comes the total knee arthroplasties. This is how it looks like. Factors influencing successful knee replacement are the implant positioning, the limb alignment, and the soft tissue balancing. That means how to approach the knee, what to cut off, and how to place the prosthesis in. So soft tissue balance and limb alignment causes about 1/3 of all orthopedic implant failures. And that means it's a good advice to go to a hospital that has a lot of experience with those implants, because if persons are very well trained, the probability that it goes right and the outcome is really good is higher as if you would have a person who does just one implant per year. But how can this be improved? The idea is not really new, and it's obvious if you are in an engineering school that you say, well, why not taking sensors to assist knee replacement? Can't we use the sensors to make it more precise? And can't we use the sensors to monitor the outcome and probably help doctor and patient to train better? So there are different solutions, and there are a lot of opinions about those solutions. We will show you 3 different solutions here, and I don't want to share too many opinions why this is good or bad with that. This is something that we could do if we meet once in our life in person. So we have the sensor system from OrthoSensor, we have a sensor system on a research level, and we have a surgery aid sensor from OrthoLine. The last one contains a movie clip without sound from a knee surgery, and since some of you might find that a bit disturbing, we put this video at the very end so you can switch off if you don't want to see something like that. And I warn you before when the movie starts. So let me go back here. That means it's nice, but it's not, does not give sustainable data that could help you during physiotherapy, rehabilitation, or whatever. There have been other. So that was research, and I guess it has never seen any human from the inside. So now to the third one. Sorry, and do it in a way that both sides are well aligned. What about an intelligent knee implant here from the OrthoSensors page? Would be nice to have that. Post-operative remote monitoring of implants to measure the load, the position, probably the material wear, to measure if the bone is going away. Are there any motions? So is your prosthesis still fixed or is it loose? What about heat? Heat would mean there is an inflammation. What about the viscosity of the fluid in between the two components? And do implant interfaces change? That would be really cool to have a patient individual rehabilitation that can be monitored over time. However, even if it prevents long-term pain and reoperation, there's still some arguments from the surgeon side, from physiotherapists that say, well, we are the experts. We don't want to have a technical system that tells us what we have done wrong. And there's a little bit anxiety around that health insurances could sue physiotherapists, could sue surgeons, and that they probably do not overtake the complete costs if patients don't do their exercises at home. So you see, the technological advances could also come with some, let's say, more subjective objections or disadvantages from different stakeholder sides. Let's see how it looked like. We can design and develop certain sensors, for example, pressure sensors distributed over both sides in a capacitive manner, or piezoresistive pressure sensors, piezoelectric ones. So there are different options that you can use and even combine to have advantages and outweighing disadvantages. Also, electromagnetic Hall effects can be taken into account. There would be the opportunity to integrate chemical sensors, so biosensors in there. Temperature sensors are easy to do. Hall sensors for joint movement, and accelerometers to get an idea if the implant is still fixated or it's getting loose and shaking around. Also fluidic sensors, as said, to measure viscosity. So that's just a short overview to show you a little bit options how sensors, especially miniaturized sensors, could be integrated into knee joint prosthesis. That's the official end of this exercise. Want to thank you very much. Next week is the week of June 10th. There's the first test covering lectures 2 and 3 and exercises 1 and 2. That means the first exercise and this exercise. You should take some slides at hand that are to be downloaded from the ILIA system. And if you think you need more, please take also further literature into account. So, just a repetition. If you don't know what to do with the exercises, I give you the short summary here. Please have a look in the first exercise to find the slide where everything is described in detail. You have to go to the ILIA system, have to go to the part of this course where something is said about tests. You have to download them at noon, 12:00. You have certain time between 20 and 30 minutes to work on this test, and you have to upload this test at latest at 1:00 p.m. Whatever comes later will not be considered and can no longer be uploaded. That means it's more clever to start your upload at 12:55, for example, to be really ready in time when the system closes again. So that's about the terms and conditions. Over next week, June 17th, is an exercise about hearing devices. And those of you who don't like to see blood should now end this recording here. For all the others, now comes a short video clip about knee joint prosthesis implantation. And I'll switch to the next slide in a second. Here we are, the OrthoLine system. And there's no, so if you don't hear anything but me, that's fine, because that's how it is. This is an orthopedic surgeon that tells you a little bit, well, somebody approached me, blah, blah, and can't we do navigation? You can read it by your own and can stop. Important thing is that technologies has been used where people have been already used to, and they've been stuck together in a way. Here, accelerometers, for example, to put everything together in a way that it can be used. This is always the trick, make it in a way that others understand what they should do. And importantly, the others are surgeons and no engineers. This is here how it's placed on the bone, and it helps the doctor to put the knee in a way he needs it to make it happen. So I go back. This is here the only part where you see something that looks like blood. This is here the system, the OrthoLine system being placed on the bone. And I repeat that part of the story again. Here we go. Important thing, you have an online system on the screen. You can wiggle around with that system and it shows you where the best position is to place the implant. And that really helps. That does not prolong the operation and is the key for success. And with that guy stopping here, we are at the end of this exercise. I thank you very much for listening. Please let me know if you have questions. We have that question and answering area, the Etherpad in the Ilias system, where you can place your questions, and at latest once a week over the weekend I respond to your question. Thank you very much.